Hi, everyone. Let me first by thanking the organizing committee for giving me the opportunity to talk at the interest meeting. This is my first talk at this meeting, and I'm so excited and honored to be here. This is the roadmap of what I'm gonna talk about, just rough global epidemiology of HIV and COVID, the effect of HIV on COVID, the effect of COVID on HIV, both treatment and prevention, how we can optimize evidence-based differentiated service delivery intervention in COVID era, the one we learned from HIV, how we can scale up COVID vaccination in Africa, also lesson from HIV pandemic, and finish with some concluding thoughts. The epidemiology of both pandemic is quite interesting. As you can see, the epicenter of HIV is in sub-Saharan Africa, where about 70% of people living with HIV are, with a total of 38 million at the end of 2019, and the cumulative deaths so far of 37 million since the beginning of the pandemic. In contrast, COVID, as of May 2021, a total of 165 million and about 3 million deaths since the beginning of the pandemic alone. And again, interestingly, in contrast with HIV, the epicenter is not in Africa. The epicenter has been in America, in Brazil, in India, and there have been some really, it's been puzzling to understand why Africa has been spared. That's a separate talk by its own. But as if we don't know how this is going to evaluate if there is a delay in vaccine coverage. But the epidemiologies of both pandemic are quite interesting. So the question is there any effect of HIV on COVID? This has been also, a question that the HIV community has been looked at. And there is several study. I have no time to go through all of them. I just selected the major one, the bigger one from Spain, US, South Africa, and the recent DoubleCho Global Clinical Platform study. The first one from Spain, published in the Annals, about 70,000 people with HIV on antiretrovirals, so quite big study. HIV did not increase susceptibility of SARS-CoV-2 and did not increase outcome severity of COVID. Of interest, a patient receiving tenofovir, but not TAF, had better outcome. The second study, this time in US, about 3,000 people with HIV, similar rate of COVID diagnosis to those without HIV, but there was higher rate of hospitalization and higher mortality, people with HIV. And also of interest here, folks with CD4 below 200 had higher mortality rate. And then going to South Africa, this is in the public health sector. Andrew Bull published in CID showing that the standard mortality rate ratio for COVID death in folks with HIV was about 2 times higher. And interestingly, here also, tenofovir, folks on tenofovir seems to do better. And folks with CD4 below 200 had higher mortality. And then, as I mentioned, this is the global clinical platform, DoubleCho massive study presented at EIS by Silvia Bertognolo. This is anonymized patient-level clinical data, about 168 HIV patients from 24 countries, quite very well representative globally. Just to go to the results, among people with HIV, they did confirm the traditional comorbidity of higher elderly, male sex, diabetes, hypertension, independently associated with COVID. But what was really important here, they really did sit with much conviction the association of HIV with COVID severity. As you can see, relatively narrow confidence interval, very narrow confidence interval, but also in hospital mortality, again, a very narrow confidence interval. So next question also been puzzling us is what the effect of COVID on people living with HIV. So this is really a no-brainer. And this has been exemplified in the New York Times. The pandemic is hiding victim, sick or dying, but not from the virus. So actually, as you may have experienced from friend, colleague in the community, this pandemic has been have indirect effect on mobility and mortality by delaying HIV treatment and prevention services and increasing loneliness, substance abuse, and depression, not only in the general population, but obviously in HIV, who are already vulnerable. And this is just a selected list of indirect effects. The list is quite long, but we don't have time to go through all of it. And the modeler, this is UNAIDS modeler, they look at what the potential cost of interruption of HIV services in Africa. And as they calculated and estimated total AIDS-related death with a 6-month interruption of heart of about 1 million. So this is the part, I think, where we can try to make a difference. What can we do? And there is almost 4 pillars here, trying to look at susceptibility, improve testing, try to impact prevention and treatment. So all are evidence-based intervention proven, through robust study design, mostly randomized clinical trial. The impact of counseling, economic, social services, substance abuse, mental health on decreasing susceptibility of both HIV, but that can be adapted for COVID. Testing, we know about testing either at emergency setting, testing in community, home by home. So those interventions can also make a difference in the COVID era. Prevention and treatment, this is also differentiated service delivery model where you bring the services to the patient to prevent them to have in-person consultation at the clinic. We can really scale up and improve, optimize their implementation. And this includes, multi-month antiretroviral supply or PrEP supply, phone visit, telemedicine, SMS adherence support, improve quality and access of oxygen and high ICU scope and quality. This is mostly for COVID patient. So this is just the next 2 slides show you some of those evidence-based interventions. This is a 12-month cluster randomized trial in Lesotho of 3 versus 6 month dispensing of antiretroviral among stable HIV adults. And as you can see, this is a non-inferiority trial showing there was no difference in retention or virological suppression for stable HIV patients receiving multi-month dispensing antiretroviral with community-based differentiated model when compared to facility-based standard of care model. And this from my own group, we presented at CROI in 2020. So this is in South Africa private sector, health sector. We demonstrated that positive impact on adherence and virologic outcome, dispensing of antiretroviral with home delivery compared to facility refill. So those interventions have been proven effective and can be optimized. So before closing, let me also bring your attention to our perspective. My colleague and I wrote in the New England Journal on how we can learn from the HIV pandemic, about our recent effort in the CDC Africa and globally COVAX scaling COVID vaccine in Africa. And this range from health infrastructure, key population at risk to target, prevention and treatment reluctance, hesitancy, and stigma, communication, and obviously prevention and treatment in vulnerable group like pregnant and children. So there is some similarity. While those pandemics are different, there is some similarity in the approach we took for HIV that can be shared. And I have no time to go in detail, but this is open access at New England Journal. You can go and read from it. So to conclude, people with HIV often present with the same clinical sign and symptom of COVID as people without HIV, and the vast majority recover from COVID. Also, people with HIV who are on antiretroviral and have normal CD4 counts, the clinical outcome is likely more dependent on factors that to affect risk of in COVID, including age and comorbidity. However, HIV-infected patient not on antiretroviral or with unsuppressed viral load or have low CD4, I think the data presented here convince you that they may be at excess risk of poor outcome, and we should definitely try to optimize those by using those evidence-based intervention. Lesson learned from HIV pandemic: consideration about health infrastructure, local epidemiology, responsiveness to local concern and belief are critical to end the COVID pandemic, not only in Africa, but globally. So let me stop here by acknowledging my collaborator in South Africa at University of Pittsburgh and at Johns Hopkins, and most important, also important, my founder, mostly at NIH. And also I acknowledge a colleague who contributed slide to my talk. Thank you very much.